Great, thank you very much. And yeah, as Hannah was saying, I'm going to be speaking about digital health compliance with a focus on what you really need to know at quite a high level, and then also some tips about what you need to do if you're kind of working in this space. Very briefly about me, so I'm a doctor by background. I've practiced clinically in the NHS for over 8 years. I still do practice clinically based in London. I'm a respiratory medicine, internal medicine registrar, if any of you are clinical, and I've also been involved in kind of the digital health tech space for a long time. I'm a clinical safety officer for a number of suppliers to the NHS, and I'll come on to what that is if you've not heard about that already. And I've also co-founded a company called Assuric, and Assuric is primarily a software platform that helps both digital health companies and healthcare organisations make sure they're on top of everything when it comes to compliance. We also offer a lot of services when it comes to clinical safety officers, data protection officers, or other kind of compliance expertise. Obviously, conflict of interest there, but this is very much not a sales pitch. This is an educational talk, so I won't mention that again. If you did want to connect with me on LinkedIn, there's a QR code there. Feel free. I'll also show it at the end, or we can just chat afterwards. So what we'll cover is broadly why compliance matters. Why do we do it? What the specific regulations and standards are that exist. Do I need them, or do you need them? What do you actually need to do, and where can you start? More specifically focusing on data protection, so data compliance, specifically GDPR, the Data Protection Act, information and cybersecurity. These are sort of the standards that people follow as Cyber Essentials and ISO 27001. I'll go on to talk about specific NHS requirements, which are the NHS DSPT and DTAC. Don't worry about the acronyms, I promise I'll go into them later. And then also the digital clinical safety requirement, DCBO 129/160. Again, I'll go into that if you've not heard of it. I'll also be covering a bit about medical device regulation. What I won't be covering today, which might be relevant to some, is CQC regulation, which is the regulator of healthcare services. For example, hospitals, GP practices, they're all regulated by the CQC, but also some digital health companies, if they're providing a service directly to patients, employing clinicians like doctors and nurses, you might also need to be aware of CQC regulation. I also won't be covering the FDA, which you may know is the US regulator of medicines and medical devices. Let's get into it. Why compliance? Lots of reasons why it's important to comply. One of the ones that people care most about is often it's a legal requirement. Not all of it is legally required, but a lot of it is. Some examples I'll come on to are like GDPR and DCB standards. And often these are sort of a legal requirement or broad requirements because there's risks attached to digital health products. There could be a risk of sensitive data breach, there could be a risk to patients, resulting in harm, and subsequently there can be risks of heavy fines from regulatory authorities, be that the MHRA or the ICO, and of course as an organisation there's risk of reputational damage. Often it's in contracts and procurement frameworks, so it's required, but good reasons to do this early outside of those reasons is it can build trust with customers and key stakeholders, and it can really create a competitive advantage in what is becoming an increasingly competitive space. And ultimately, you want to protect users who may be patients, and you want to build trust. So I'm going to start with cyber and information security, focusing on Cyber Essentials and ISO 27001. Who has heard of these things? Okay, that's good, a handful. The focus of cyber and information security is ultimately to keep data secure and protected, which is different from data protection, which is ultimately to protect the rights of the individual who the data is about. Okay, so why does this matter? You've probably all seen these headlines, which kind of been national headlines around major cyber incidents. Here's one. One Advanced was fined 6 million by the ICO. For those who don't know, the ICO is the supervisory authority who sort of governs and makes sure data protection legislation is adhered to in the UK. And they fined One Advanced 6.1 million for a breach where sort of a huge amount of patient data was stolen. And the root cause of this was from an account that didn't have multi-factor authentication. So one user who didn't have multi-factor authentication, someone got in, stole a lot of data, and resulted in huge fines and a huge amount of sensitive data being leaked. This is also one you've probably heard of, the Synovus cyber instance. This was only last year affecting London hospitals. Synovus is a laboratory supplier to the NHS, and as a result, tens of thousands of cancelled operations and appointments occurred. and this was at an estimated cost of 32.7 million. And then later analysis realized that there was at least 2 cases of severe harm and at least 10 of moderate harm to patients as a result of this. Ultimately, if a criminal gets in, steals the data, with ransomware, they basically stop everything until the NHS pays. They may or may not pay, but as a result, there's huge disruption, and that's why there's huge numbers of cancelled operations and appointments. And these attackers often target kind of the supply chain, and often these incidents are due to third parties. So that's why it's important that the supply chain of data is secure, and that's why it's often requirements for digital health suppliers to make sure that they're doing everything properly when it comes to patient data. Okay, so why is this particularly relevant to people working in this space? It's because of health data. So health data, as I'm sure you're aware, is special category data. This is a GDPR term, and it's more sensitive than personal data, and therefore it's more attractive to attackers. And as a result, healthcare is hit 4 times more than other sectors, and data breaches have increased 74% year on year from 2023. And just as an example, healthcare can just have the highest data breach cost of any industry. So an average per incident is around $10 million in that study. So it's very important. Okay, so am I at risk? Are you at risk if you processing patient data in this space? Even if it's small scale, you might think, oh, they're not targeting me, but ultimately, even small organizations are at risk. And why is that? So criminals target health data because of the high value of medical records, compared to even credit card information, which here is estimated to be around £4 per record. Electronic personal health information is at least 10 times the value of that. And then that's why it's such an attractive target for attackers. And then ransom payments are also paid far more often than other kind of ransomware attacks, and that's partly because of the huge disruption that occurs. So that's why it's such a sensitive kind of area and why it should be protected. So, and that's why these standards, compared to other industries, are kind of expected at all stages. And these are what we can do to ultimately reduce the risk, and why these frameworks like Cyber Essentials and 27001 exist. So I won't go into all the details, but just very high level of kind of what is expected from cybersecurity. Often you may have heard of the CIA triad, which stands for confidentiality, integrity, and availability. Very briefly, confidentiality ensures that the sensitive information is accessible only to authorized users. Integrity ensures that the data is accurate and not corrupted. And availability is that it's accessible when needed and only by those who need it. And then you can also add on compliance. So to achieve this, you can comply with standards and frameworks. And then resilience is sort of being able to recover data when things go wrong and you need to do backups and things like that. Okay, so I'll go into a bit about both of these, but also I'm going to mention the NHS DSPT, which is another standard specific for the NHS, called the NHS Data Security and Protection Toolkit, and other things you can do, like doing what's called a penetration test, which is another sort of thing you can do to make sure that you're keeping data securely. I'll just do very high level about what these are. The Cyber Essentials is a UK-only standard, and it focuses on the most common cyber threats. It's very basic. It's a good starting point. It's self-assessed, but you can also do an external audit, and it's required as part of NHS DTAC. So NHS organisations will generally expect you to have the certification before they let you do things like pilots or deployments. ISO 27001, on the other hand, is a lot heavier. It's internationally recognised, and it's around implementing what's called an information security management system. It's not mandated as part of deployments into the NHS, but if you're a large organisation, it would be expected. So, a bit more detail. As mentioned, this is something you would expect small organisations to do, and it focuses on 5 of the key control areas that is generally expected, and that should prevent the vast majority of common cyber threats. And these are high-level security configuration, so making sure what you're building is secure. User access control, so only people who have the right to access can access it. Malware protection, so antivirus and things. Making sure everything's up to date, because non-up-to-date software is a huge vulnerability, and other things like firewalls. easy place to get started is going on the IASME website, which is the certification body. You can do an online self-assessment, and then you can also do an external audit to obtain what's called Cyber Essentials Plus. I'm actually seeing the NHS organisations are expecting Cyber Essentials Plus more and more, so worth considering. ISO 27001, as mentioned, it's all around building and implementing an ISMS, or Information Security Management System. And then this includes implementation of a much higher number of security controls. It includes lots of things that aren't covered by Cyber Essentials, so things like physical access controls if you have an office space, threat monitoring and vulnerability scanning, encryption of data both at rest and at transit, and then to obtain a certificate for this, you need to go through an audit and certification process, which should be done by what's called a UCAS accredited body. Just to your awareness, there's lots of suppliers of ISO 27001 certificates, but the sort of the most robust and sort of valued way of doing this is with a UCAS accredited auditor, and that's generally what's expected when it comes to certification. And then if you're at this stage, or your clients are at this stage, the best place to start is to go download the standard and look at it. Okay, I'll just pause there because that was all around information security. Before I dive into data protection, were there any questions about that side? Good stuff. Okay, I'm going to go into data protection. As I said, this is legislation around protecting the rights and freedoms of individuals, and it's underpinned by both the Data Protection Act and GDPR in the UK. Mandatory disclaimer, this is not legal advice. If you're ever in doubt, consult an expert legal opinion. And the ICO, who is the supervisory authority, they have a very good website with lots of guidance designed to help anyone from small to large organisations make sure they're complying with the regulatory requirements. Okay, so who does this apply to? Anyone processing personal data of individuals in the UK or EU, depending on where you are. It's underpinned by the legal framework GDPR and the Data Protection Act, as mentioned, and personal data is defined as any information that can be used to identify a person, either directly or indirectly. I'll just stress that point that indirectly means that if you have some data, maybe it's missing names or something, but if you were to still be able to identify a patient based on that data, then it would still be counted as personal data. So that's just something to be aware of. Similarly, if you fail to comply, there's significant penalties which are given by the ICO, large fines. So yeah, something to be aware of. Okay, I'll go into just some of the high-level stuff about what underpins GDPR and then go into some more practical steps about what actually needs to be done. So GDPR is underpinned by 7 key principles. 1, lawfulness, fairness, and transparency. So ultimately, if you're processing or storing data about an individual, you have to be very open and transparent about what data you're collecting, why, and the reason you're doing it. There's also requirements around purpose limitation, data minimization, and storage limitation. The idea being you would only collect the personal data you need in order to complete the task required. You don't collect sort of reams of data about someone and then just for no reason. Integrity, confidentiality, and accuracy. You have an obligation to make sure any data collected about an individual is accurate, and then also it's processed securely, and so you're implementing security controls like we mentioned before. And ultimately, you need to be held accountable, and that can be to both the ICO and having responsible individuals in an organisation who can sort of ensure that this is all adhered to. But in terms of what this actually means in practice, these are the basics for kind of an early stage company should do if they're processing personal data. Firstly, everyone needs to register with the ICO, and this is done online. Then, as a starting point regarding transparency, you should have a privacy notice, which should be published on your website or in your app. And this outlines essentially to the data subject what data you're collecting, where it's being, why, what the purpose is, what the lawful basis is, and what the rights of the data subject are. And then it's very important to know your data, and I've seen companies not do this very well, but ultimately you want to have a good understanding of where data goes, so document your data flows and your processing activities. Some of you may have heard of the term of a ROPA, which is called a record of processing activities. This is a standardized document for helping you break down what data processing activities are, where the data goes. It's important to understand your role, and there's this concept of a data controller versus a data processor. I'll come on to that a bit later. you have to understand the basis in law for processing personal data. So every processing activity should have a basis in law, and these can vary from consent to other. And you also need to make sure you have DPAs, which are data processing agreements in place with third parties who you share that data with. You need to appoint a responsible individual. This could be a data protection lead, or with health special category data, you might be expected to have a DPO or a data protection officer. This is expected if you do large-scale processing of special category data, which a digital health company would probably expect to do. And you may have heard of DPIAs, which is a data protection impact assessment. Again, if you're processing special category data, you're generally expected to do this risk assessment to see what risks are and whether additional controls need to be implemented to reduce the risk of any sensitive data being leaked. It's very just high-level overview of some of the practical things that need to be done. Okay, lots of people get quite confused about this, so I thought I'd just break it down in a diagram. But this is one of the most common relationships that a digital health company would have. The digital health company often would be a data processor on behalf of an NHS organisation, a data controller, or a healthcare organisation, and the data subjects might be patients. So the data controller has, say, patient data, and then they might procure a digital health company to process the patient data on behalf of them. Therefore, the digital health company is the data processor. And then that data processor is probably going to use third parties to also process that data in order to perform the tasks that they're required to do. A classic example of these sub-processors are the likes of your cloud providers, AWS, Azure, and GCP are on the screen. That's Google Cloud. But you might have other sort of third parties that you use, like authentication systems, communication systems. You might not put everything in-house, so you have to have an awareness of where the data is going with these other sub-processors. And then on top of this, you need to have those data processing agreements in place. So there needs to be a contract between the data controller and the data processor in the form of a data processing agreement, which again outlines what data is being shared, what the purpose is, what the lawful basis is. And then similarly, there should be data processing agreements in place between the digital health company and the sub-processors. And then generally, these are standard documents. But there's important, they might not be sort of there out of the box, and you might have to do some configuration with, say, your cloud providers to make sure data is being held in a sort of GDPR compliant way. You also would be expected to do a DPIA if you're processing patient data. Again, this is a risk assessment, a data protection impact assessment, and often you might need to support the NHS with completing their own data protection impact assessment. And this is something we see a lot. You also would need to implement security controls to make sure that the special category data you're sharing with any sub-processors or that you're dealing with internally is secure. And this goes back to implementing things like Cyber Essentials, ISO 27001, other security controls. And one thing to be aware is you need to be aware of international transfers. So where's the data going? And generally the expectation would be, ideally it would be held in the UK or the European Economic Area, because this would be compliant with GDPR. Any international transfers, say if you're using a sub-processor that has their data centers in the US, you have to have additional clauses in the contract to make sure that that data is held in a compliant way, and the NHS would ultimately have to agree to that. So that's why it's quite complicated when it comes to information governance and sort of sharing of patient data. Okay, so NHS compliance. Focusing on the DSPT, the DTAC, DCB 129. So the DSPT, this, which I mentioned before, this is the NHS's additional layer of requirement on top of GDPR compliance, Cyber Essentials, ISO 27001, and it's called the Data Security and Protection Toolkit. So this is an annual online self-assessment that any company who sort of deploys with the NHS or processes any NHS data needs to complete, or if you're a large health IT supplier, which is defined as an organisation of greater than 50 employees or greater than £10 million in annual turnover, then you would need to do an external audit on an annual basis to make sure that you're meeting the requirements as well. It takes a lot of basically evidence of GDPR compliance combined with a number of evidence of technical assurance and controls, so things like access controls. There's a lot around making sure staff are appropriately trained, and there's a piece around business continuity as well. As part of it, you're expected to have things like Cyber Essential certification, and you're also required to do what's called a manual penetration test, which is if you don't know, is when a third-party organization comes in and basically tries to hack your system, checks for vulnerabilities, and then if there are any vulnerabilities, reports them back to you and make sure that those are patched and remediated. And that report is the evidence that NHS organizations or auditors will want to see. In terms of where to get started, in order to access the online self-assessment, you need to get an ODS code, which you can apply for online, and then you can start reading about the DSPT through their big picture guides. Okay, so moving away from data governance, information security, more onto the kind of clinical safety side. So DCB 0129 and 0160. Have people heard about this? Yeah, good. So this is digital clinical safety for health IT systems. It's a law in England that health IT systems need to meet and deploying organizations. But why is it important? Well, firstly, the reason this exists is healthcare is obviously a high-risk industry and safety is incredibly important. Therefore, it's highly regulated. The reason is there is a huge number of avoidable deaths. So in this one UN study, unsafe care was in the top 10 leading causes of death in the world, and it's estimated up to 83% of harm is avoidable, and this extends into digital health solutions. It's a legal requirement as part of the Health and Social Care Act, which I've mentioned. It's often a contractual and procurement requirement, and ultimately it exists to reduce the risk of patient harm, as opposed to everything I spoke about before, which exists to reduce the risk of patient data breaches or issues around data. And of course, if there's patient harm, it will bring reputational damage to an organization as well. Okay, some headlines. Similar to data breaches, digital health companies, health IT systems can also lead to patient harm. Any solution can introduce clinical risk, which can lead to patient harm, and this extends to all digital health solutions or health IT systems, not just software as a medical device. And that's why this standard doesn't just apply to medical device companies, but all digital health solutions. Some headlines. Last year, there was a report in the BBC about hundreds of avoidable cases of harm with a number of potentially avoidable deaths linked to health IT systems. And then there's some other headlines demonstrating things that have gone wrong in the past. The cardiovascular risk calculator is a classic one where at the time it wasn't just deemed to be a medical device, and then the Q-risk score was basically, you may have heard a Q-risk score is a cardiovascular risk prediction score, and it was just the calculations were all wrong. So people were being prescribed lots of medications that they didn't need, and it was found that just the calculator was wrong, and subsequently those kind of calculators are now expected to be certified as a medical device as a result of an incident like that. Okay, so this is a dual standard. I mentioned 129 and 160. The reason is DCB 129 applies to the manufacturer of a digital health or health IT product. 160 applies to the deploying organization. So the NHS actually does a huge amount of work on this as well. It includes all health IT systems, as mentioned, not just medical device software. And it's mandated in law, and the focus is on patient safety, as mentioned. So briefly, high level about what's actually involved in this process. An organization is expected to implement what's called a clinical risk management system, I guess somewhat comparable to an information security management system. And this ensures that you implement a process of clinical risk analysis where you identify potential hazards with a digital health product. So where might things go wrong? Is there a risk of patient harm? If there is deemed to be an adequate risk, then controls need to be implemented to reduce that risk. And then this is all documented in what's called a clinical safety case, formed by 3 core documents: a clinical risk management plan, a hazard log, which is basically your risk register, and the clinical safety case report, which kind of synthesizes everything and presents it as a report that says, based on this risk analysis, this product is deemed safe to use. And this whole process is overseen by what's called a qualified clinical safety officer, or CSO. And the starting point for digital health companies is to appoint a CSO to kind of start this process. And these can be internal, or they are sometimes external as well. Very briefly, according to the standard and the legislation, a CSO needs to be a qualified and experienced clinician who has a current registration and license to practice, who is also knowledgeable in this domain of clinical safety. They have overall responsibility for sign-off and overseeing the whole process. Just a note that these DCB standards are actually ongoing a review at the moment, so they'll probably be updated in the next couple of years, but the feeling is there won't be major changes. Okay, DTAC. Who's heard of DTAC? Yes, people have heard of DTAC. Digital Technology Assessment Criteria. People get a bit obsessed with DTAC, but the bulk of what DTAC is, we've already covered. And DTAC was created a couple of years ago primarily to try and make the process of digital health assurance and due diligence a bit easier for healthcare organizations and a bit more standardized. So they basically bucketed up a lot of what we've spoken about and added some other bits on the end to try and make sure that any new digital health products go through this kind of due diligence process. And it's broadly separated into data protection, so compliance with GDPR and the DSPT, as mentioned, doing things like a DPAA, your basic cybersecurity requirements like Cyber Essentials penetration testing, sort of evidence of compliance with clinical safety and having a named clinical safety officer. And then the additional components they add on are an expectation around demonstrating your interoperability, so if you're using any APIs or integrating with any systems. And there's also a part around usability and accessibility, which on a basic level is making sure you've done some user journeys and usability testing, have an accessibility statement, and made sure that your product is accessible to a degree, the ultimate being complying with what's called the Web Content Accessibility Guidance, or WCAG. It's not expected to meet sort of every single point of that, but it's the more the better, and that's actually a scored part of the DTAC. Just some myths around DTAC. They've actually been reviewing it for a long time, so there might be some changes, but this is from NHS England. They basically say it is expected for pilots. One thing to be aware of, it's not something you get certified, so there's lots of DTAC certifiers who may give you a certificate to say your DTAC's okay, but that's not a requirement. It's just something that you can get done. And it also applies to medical devices. So this is another kind of expectation for digital health companies. And again, this is specific for the NHS, so anyone deploying into the NHS. Okay, so a lot to cover. I'll just pause there. Any questions on the NHS side before I go through some medical device regulation? Good. Okay, I'll chat about medical device regulation. Main focus being on SAMD, or software as a medical device. A lot of it is still relevant to non-software medical devices. Again, I'll focus on the UK market, so the MHRA, UK MDR, which is very similar to EU MDR, but some slight differences. But I won't be covering FDA, which is a bit of a step difference to the UK MDR. The MHRA is the ultimate regulator, the Medicine Health Research Authority, so they regulate medicines as well as medical devices. UKCA is the mark you get once you've obtained your certification, equivalent to the CE mark in the UK. So you often see that on kind of physical devices. You might see that certificate, that mark, but it also applies to software. Okay, so why does medical device regulation exist? So similar to the DCP standards, it ultimately exists to ensure that patients are safe. Healthcare is a regulated industry. Devices used in healthcare need to be regulated. It's ultimately because patients are at risk, but there's an added element of requiring evidence of clinical effectiveness as well as safety. And that can be a challenge in some cases. Like everything we've spoken about, there are consequences of non-compliance. This can be products being withdrawn from the market. This can happen after achieving certification. So there's a requirement around post-deployment monitoring and post-market surveillance. And then if it's not met, these products can be withdrawn, and that's not uncommon. And similarly, like the ICO, you can get fines from the MHRA. Okay, so a question for any digital health company or medical device potential company is to work out, is my product a medical device? And this is a very, very common question that I hear a lot from software companies. And there's two main sort of ways to think about it. Firstly is to be quite clear about what the intended purpose of the product is as a starting point, and then sort of asking the question about whether this intended purpose is a medical purpose. And a very sort of high-level definition here that a medical purpose is having a function of preventing, diagnosing, monitoring, or treating a disease or injury. And some examples about what isn't a medical purpose is, say, a medical education tool or the wellness market, where these are marketed to kind of well people as opposed to people with pre-existing conditions. And then things like EHRs, so electronic health record systems, which store or transmit medical data without change. They would not be a medical purpose, but they would meet the requirement of DCB standards. So this is the actual MHRA definition in a bit more detail, but again, performs a medical purpose, such as diagnosing, monitoring, or treating a medical condition. And then they've kind of extended this definition to kind of informing clinical management. And I'll come on to some sort of grey areas in a bit. A very useful resource if you're interested in this space is the MHRA flowchart, which is available online. It's quite easy to find. Just thought I'd mention it. And then the next question is, if you've determined your medical device or potential medical device does meet the criteria, you need to establish what risk classification it is. So this extends from class 1 being the lowest risk up to class 3. And then generally the way that risk classification is thought of is about the influence a product has or the output has over a medical decision. So this can be on the lowest end, informing clinical management. So it might suggest something to a clinician, but ultimately the clinician has other sort of data points to make a decision, or a large influence, which is given the term driving clinical management, or even higher than that is ultimately treating or diagnosing. And then alongside that, the health condition that it's being used in is another determinant of risk. So from the non-serious to sort of low-risk conditions in primary care, all the way up to sort of your critical care software or hardware would be a much higher risk. And this ultimately helps you decide where on the scale from 1 to 3 that risk would be. I think an important point is we see a lot of class 1 software devices or ones that self-certify as a class 1 device. This is quite appealing because it's a self-certification. What this means is you don't necessarily have to be examined by a third party. You just have to do a declaration of conformity saying, yes, I do conform with the requirements, and then that makes you open to audit from the MHRA. But it's not sort of the robustness of those devices can vary. But what we're seeing in Europe is essentially, some would argue every single software as a medical device in Europe would be class 2A or above, although some people argue the difference. But what we're seeing is the UK MDR is going to align more closely with the EU MDR, and therefore there's a chance that all current class 1 devices might be upregulated to class 2A and then have to have an external conformity assessment. So just something to be aware of. Generally, most people would see most software as a medical device would be class 2A or above. And then in terms of how all this regulation works, just again, some people get a bit confused by this, so I thought I'd just make it clear. In the UK, we have the MHRA, which is the ultimate supervisory authority, and then they regulate what's called UK-approved bodies, or the equivalent in Europe is a notified body. And these are organisations like BSI, which is the British Standards Institute, some other ones you may have heard of. Scarlett is a newer entrant they're a kind of startup themselves, but they're a tech-enabled notified body specialised for software, so one to look out for. And then, so these approved bodies or notified bodies, they do the conformity assessments, the reviews of the medical devices, and once they've kind of granted those certifications, then they can be registered with the MHRA, and the UK CA mark affixed to the device. The equivalent in the EU would be the CE mark. Just one word on the FDA. So it's slightly different in the US. The FDA actually takes on both of these roles and just takes on all responsibility. And their equivalent of a UK CA mark is being FDA cleared or FDA approved, depending on which pathway you go down. But I won't go into the details of how that works today. Okay, just to get an idea of people's understanding, I first thought I'd go through a few case studies, starting with quite an easy one. So AI radiology diagnostics, some of the bigger players in the market are like Brainomix, which does stroke radiology detection, and it has a very high NHS penetration, so above 90% of the NHS, I think, are using it now, stroke centres. Annalise they have a kind of chest x-ray product. Chiron Medical is well known for having their mammography diagnostic tool. So would you say, are these medical devices? Yes, very good. What about instant messaging and photo sharing? So some classics, Accurix is a very well-known one. Would these communication tools be medical devices? Who says yes? Who says no? Yes, very good. So yeah, broadly, if they don't change the information, they wouldn't be a medical device. VR simulation training for doctors, one example company here. Medical device? Not medical device. Yeah, so not a medical device. So anything in training is not. So some companies choose to go down this route for it's not regulated. AI ambient scribing tools. So some of the ones that have quite a big penetration in the UK now are Tortoise, Tandem, and Heidi. And then Microsoft also have their Dragon Copilot. Some of you might have heard of. Do people know what these tools are? Ish. I'll just explain briefly. They're kind of having a very big impact in sort of direct clinical care now. They're basically, at the face of it, they're an AI speech-to-text tool, which listens to a consultation and you get a transcription, and then a large language model would then produce a note, a clinical note, which can then be saved into the medical record. So essentially, the clinician wouldn't have to document a patient consultation, saving a lot of time. Who thinks these are not a medical device? Yeah, a couple. Anyone for a medical device? Good split. That's good because no one really knows. Medical device regulation regulates not the technology, but the intended use of the technology. So it's about the tools. So for example, a knife would be outside of a clinical environment would just be used as a knife, whereas in a surgical environment, it's a surgical scalpel, and then it needs to be regulated as a medical device. Similarly with LLMs, if you use ChatGPT for asking about the weather or whatever you like, not a medical device, as soon as you use it for a medical purpose, it's a medical device. And in ChatGPT's terms of conditions, they say this is not to be used for a medical purpose. Of course, that's difficult to control because clinicians probably, I imagine a few clinicians are using ChatGPT for that purpose, which is not regulated. Ultimately, that's that clinician's registration and responsibility on the line. Whereas if it's being marketed as a diagnostic tool, then it would definitely be a medical device. The scribe tools are a challenging one because they market themselves as an administrative tool, so they're saving clinicians time, but they're not doing any diagnostic step because they wouldn't then, after the consultation, suggest a diagnosis. They'd only report a diagnosis if it was said in the consultation. And that's why they've been operating without needing to be certified as a medical device for over a year now. And I can see the arguments either way, but because of the way they're being used in a clinical setting with a high-level function of summarization by a large language model and the risk of important data either being missed or incorrectly added through hallucinations, then they are now expected to be classified as at least a Class 1 device. And NHS England are actually going to, they've recently published some guidance, but they're going to publish more guidance, and the feeling is they're going to be more explicit about what they expect of these tools. So yeah, a very interesting area. Yeah, the move is LLMs, even if used in a kind of administrative tool, would still be required to be medical, sort of certified as a medical device, at least a Class 1. If the LLM is being used as a clinical decision support tool, so going a step further when they actually suggest, say, a differential diagnosis or a management plan, they would be expected to be a Class 2A or above. Well, none of those are on the market yet, but people are definitely developing them and testing them. And some of them are being used in the US, but they have less rules around clinical decision support tools. You can get away with a lot more outside of FDA purview there. And then I'll just mention, similar to AI scribes, we've already kind of covered this now, but AI discharge summary writing, what's the feeling? Would that be a medical device? Yes, exactly. And then the reason I put this here is because one of the arguments about AI scribe tools not being a medical device is the low risk in the sense that the information is directly returned to the clinician who's carried out the consultation, and therefore they can check it and correct it straight away. Whereas an AI discharge summary tool, no one's going to go back through the notes and check every single note to see if the information is accurate. So there's a kind of higher risk that incorrect information will just be saved into the record, and then people down the line might make clinical decisions based on that information. But yeah, it's obviously an evolving space. This regulation was written before things like generative AI and large language models. And I think the definitions actually don't go far enough now because technically I don't think an ambient scribe is doing diagnosis. So the definition, I think, you could argue based on the current definitions, they're not. But I think those need to be reviewed to be more up to date with new tools. Okay, I've spoken about this before, but these are common things that aren't software as a medical device. So electronic patient record systems, so your big systems like Cerner, Epic, etc., they are not because they just transmit data without change. Communication tools, certain decision support tools aren't medical devices if they, again, just transmit data like guidelines without change. and medical education tools, wellness, etc. Administrative functions, again, I mentioned the grey area with scribes. Okay, so I'll just go through kind of high level what is generally expected to get certified as a medical device. If for a class 1, generally it's a self-certification, but you would be expected to define your intended use, compile some technical documentation, do a clinical evaluation. But for a class 1 device, you might be able to get away with just doing a literature review if there's enough clinical data in existence. And then you would compile all of this. You would also have a lightweight quality management system, and then you would sign what's called a UK Declaration of Conformity. So you as an organisation are saying, yes, I conform to MDR, and then you would then register with the MHRA and affix your UKCA mark. And then you would also be expected to do post-market surveillance, and you'll be open to being audited by the MHRA at any point. And then for 2A or above, there's a higher burden, as you might expect, because it's higher risk. So again, I won't go into all the details, but you would generally, it's good to engage with the MHRA and approved bodies at an early stage, so you can work out whether you're a medical device or not, or what you need to do. Everything was always underpinned by the intended use statement. So this is one of the first documents you would write, outlining exactly what the product does, who is it intended to be used by, in what setting it's intended to be used, how might it be misused. This is kind of forms the basis of what the product actually does. And then you would go down a kind of two main processes of building up all of your technical documentation, which will be, you'll have a quality management system, which is basically a lot of policy and procedure documentation to make sure quality processes are followed. And then this is underpinned by an ISO standard called 13485, which you may have heard of. There's also a newer one for AI systems, 42001, which is sort of a standard for an AI management system. I just bring this up because the EU AI Act would generally expect medical devices to comply with a standard like ISO 42001. At the moment, not as relevant to the UK, but I'll just mention it. And then if you're a software company, you also have to document everything when it comes to your software lifecycle processes, your software requirements and how they link to other parts, doing usability testing, etc. You have to have a risk management file, which complies with ISO 14971. This exercise is not dissimilar to the DCB risk analysis. And then you write this all up in a huge amount of documentation. Alongside this, you need to do a clinical evaluation. And there's different steps and requirements, but you would generally be expected to do things like a benefits risk analysis, a literature review, and then an actual clinical investigation, which might be something like a clinical trial or a clinical study. You would generally be expected to get ethical approval from this, from the Health Research Authority, and then comply with things like good clinical practice when carrying out the study, and then write this all up in your kind of clinical evaluation report and clinical evaluation file, and then you would submit these to the approved body who would do their conformity assessments, assess your technical and clinical documentation, and then grant your UKCA. Well, they would certify you, and then you could then register and get your UKCA or CE mark in Europe. And then it's not over then. There's a requirement around post-market surveillance, so you have to make sure you're continuing to assess the safety and effectiveness of the product and collect appropriate data, which you then also have to periodically submit to the approved bodies. And then there's also a requirement around economic analysis. And this is, so you might have demonstrated your device is safe and clinically effective, but you also might have to demonstrate that it's cost effective. And then you can do this by doing a health economic analysis, and NICE have published what's called the Evidence Standard Framework, which is some guidance to kind of do that body of work. And then some devices get sort of NICE approval if they demonstrate this, which is useful for kind of distribution across healthcare systems. That's a lot there. This is very high level, so take it with a pinch of salt, but just give an overview of everything we kind of spoke about and how it might fit into a timeline for a digital health company. Not all of it's relevant to everyone, but just to give you a bit of an idea. And I'll take some questions. Again, feel free to email me if you want to chat about anything else at a later date, or follow me on LinkedIn, or just catch me after.